Okay, hi everyone. Thank you so much for having me. I'm excited to talk to you today. I know the chiefs had asked for a little bit of BMT and a little bit of SOT, which is solid organ transplant, but I'm actually, if it's okay, just going to do like a solid organ transplant talk today, Transplant ID 101. And the reason I chose to do that is because SOT is actually, pretty different from BMT. And actually on the east side where I am, we have 3 different transplant ID services, and BMT ONC is a whole other separate service, ID service actually. And that's because the approach to them and how they're managed are actually pretty different. And so I'm going to focus on SOT today, but I did want to say I'm really happy to come back and do a BMT. And I find that BMT pairs very well with neutropenic fever. So I'm happy to come back and do a BMT neutropenic fever talk next time, okay? But today I'm going to talk about solid organ transplant, which is really, we are a pretty big solid organ transplant center here on the east side. So for those of you who don't know, we do about 125 to 150 liver transplants a year, about 200 kidney, and about 20 to 30 hearts, and a small amount of small intestine. And we're going to be starting lung soon. So pretty big solid organ transplant center. And so with that comes a lot of transplant ID. And that's my area of focus and what I'm going to be presenting to you today. So briefly for our outline for our talk, we're going to start with an introduction, followed by talking about risk of infection. We're going to talk about the timeline of infections, which is a really important and key concept in transplant ID. And then we'll go through cases. So why is transplant ID even exist? Why is transplant ID a subspecialty of infectious diseases? And that's because for those of you who have seen transplant recipients, you know that it can be pretty difficult to recognize infection. Not every transplant recipient who has an infection may present with a fever. And sometimes they can have fever, but it may not be infection, right? It could be something else like rejection. Transplant ID, there's other unique nuances to the management because that can also be different given the drug-drug interactions. And we'll talk a little bit about that today. So when you're seeing a transplant patient and you're rounding with me, the first thing I ask you is, what is that transplant patient's risk of infection? And how do we think about risk of infection in a transplant patient? Well, these are the factors that we consider, and we're going to go through each of these individually. So the first thing we're going to talk about are the different epidemiologic exposures that particular recipient may bring to the table. Then we're going to talk about what the net state of immunosuppression is. And then we're going to talk about where they are in their transplant timeline. So let's start with donor-derived infections. So donor-derived risk factors are usually something we see that contribute to infection in that very immediate post-transplant period. So as you can imagine, when a recipient gets an organ, usually from a deceased donor, sometimes that deceased donor can bring infections with them that you may or may not have known about. And so sometimes we're thinking about those ones that we may not have known about. And these type of donor-derived infections have been described and can often be highly publicized. So for example, West Nile virus is an example of an infection that can be transmitted from a donor to a recipient. Usually we don't know about it, and oftentimes the recipient may present with West Nile virus meningitis, and then we have to go back and think about, could this be something that came from the donor? If we know about that in a donor ahead of time, that is not a donor organ we would have taken. So it's important to recognize that there are certain infections that are considered contraindications to organ donation. And those are donor organs that we do not use because we know those infections can be transmitted to recipients. And those include unknown infections of the CNS, active TB in a donor, West Nile, or rabies in donors, which can, if transmitted to a recipient, be very, very serious infection that can also oftentimes result in mortality. What does the recipient themselves bring to the table after transplant? So these are all things that we think about when we're seeing a recipient and evaluating them for transplant. So usually we take an individualized epidemiologic history. We ask about where they were born, where they've lived. We send certain serologies. We'll talk about that. We ask about vaccination status, and we look at their past infections. Do they have any current infections that they're being treated for, or are they colonized with any specific bugs that we should think about at the time of their transplant? And when we're seeing a candidate for transplant, these are usually serologies that we are sending at the time or before transplant. And the reason we send these is because we're thinking about risk for infection after solid organ transplant. So for example, CMV is IgG is a serology that we send because patients after transplant are at risk for CMV infection, and we'll talk about that. EBV, IgG we send because those who have a donor who may have been exposed to IgG, but a recipient who's negative, and this usually comes up mostly in pediatric transplants, may be at risk for EBV-associated PTLD after transplant. We send varicella serology because patients should be vaccinated beforehand, possible. We send syphilis for screening and HIV for screening. We send Hep A and Hep B to optimize vaccination status before transplant, Hep C for screening, and we do a TB test again for screening before transplant. And depending on where the recipient is from, we may also send some of these serologies looking for exposure beforehand. We always talk about vaccinations with our patients before transplant, and the reason for this is because after transplant, they'll be immunosuppressed. And so we want to make sure we optimize that immune response with vaccination beforehand. And this is a long list of vaccines that we typically recommend. Of course, added to this now, as you all know, is COVID vaccine. And we'll talk a little bit about that later. And then what else does the recipient bring to the table for them after transplant? Well, you are also thinking about different types of exposures, such as community exposures. Do they have children at home that they live with? That are a risk factor for respiratory viruses? Have they traveled recently somewhere? Are they at risk occupationally for TB, or do they work in the healthcare setting? What about food and water exposures? Like we think about that with Listeria and Legionella. So these are all the different types of infections that we can see in transplant recipients and where community exposures play a big role. And what about nosocomial exposures? And we're going to talk about that with one of our cases today. Are patients colonized with multi-drug resistant organisms prior to transplant that put them at risk for infection with certain organisms after transplant? So oftentimes when I'm rounding with my fellows or residents, and I'll ask them, how immunosuppressed is this patient? And that's because everyone I see is immunosuppressed. So it's not really enough to say, well, this patient is immunosuppressed. I want to know the specifics about how immunosuppressed they are. And when I'm asking that, what I'm really talking about is the net state of immunosuppression. And the net state of immunosuppression is really made up by lots of different factors. So the first factor that we think about is immunosuppressive therapy. So I want to know the specifics of the drugs that they're on, the dose, how long they've been on it, and the types of agents. I want to know, do they have underlying conditions that contribute to their immunosuppression, like diabetes, cirrhosis, HIV, for example? Did they recently have their transplant or their surgery? How did it go? Do they have central lines, Foley's, right? All of that contributes to their risk of infection. Were they recently treated for rejection? Did they recently receive rituximab or thymoglobulin that puts them at risk for further infection? Or did they have recently an immunomodulatory virus like CMV that puts them at risk for further infection? So this is all the different type of things that we think about when we're talking about a patient and how immunosuppressed they may be and how that contributes to their risk of infection. And then lastly, when we talk about solid organ transplant, we think about different time periods after transplant. So it's really important to think about how far out is someone from their transplant. So we think about this in 3 phases. Are they less than 1 month post-transplant? Are they 1 month to 6 months post-transplant? Or are they greater than 6 months post-transplant? And the reason this is important is because it lets us think about our differential. So those patients who are less than 1 month post-transplant are usually at risk for different types of nosocomial infections that we often see in the healthcare setting. like CLABSIs, CAUTIs, VAPs, HAPs, etc., or they're at risk for surgical site infections, for example. After 1 month, that is when we typically start to see, or even later, perhaps 3 months, is when we typically start to see opportunistic infections. And that's because that's when oftentimes the prophylaxis is coming off, and we start to see that, patients really start to present perhaps with OIs. And then after 6 months, OIs are still possible, as are more of those community-acquired infections, because that's when a lot of transplant patients sort of go back to, perhaps go back to work. They're more out in the community again, and they're more at risk for sort of community-acquired infections. So we'll go through cases through all of these phases today. So case 1. So this is a 52-year-old man with PSC, ulcerative colitis. He's had 3 liver transplants, and he's going to be getting a 4th. And he's noted to be colonized with the below. So, and you guys can unmute if you want and tell me how would you describe this particular bacteria here?
This will be almost like pen-resistant bacteria. Like it's only susceptible to imipenem and tigecycline.
It's actually resistant to imipenem. It's probably hard to see. It's susceptible to gent and tigecycline. So this is called, but you're right, this is called a carbapenem resistant Klebsiella. So, or we also call this CRE, carbapenem resistant Enterobacteriaceae, because Klebsiella is in the class of the Enterobacteriaceae family. And so this is, you're right, a very resistant bug. And so he's being evaluated for transplant, and we're being called now to say, what is this patient's risk after transplant for infection? So you can see how this is problematic, right? We already have a very resistant bug in the urine, and this is pre-transplant. So when we talk about perioperative prophylaxis at the time of transplant, these are the types of things that we consider. We can think about, are patients colonized with certain bacteria even before going into their transplant? We think about the type of transplant they're having. And we also think about the types of bugs that you may see at that particular institution. So here at Sinai, our kidney transplant recipients get cefazolin, primarily to cover uropathogens. Our pancreas transplant recipients get Amsulbactam and fluconazole for gram-negative coverage in Canada. Our liver recipients get gram-negatives Enterococcus coverage with Amsulbactam and fluconazole when appropriate, and we'll talk about that. And for our heart recipients, we're thinking about mostly covering staph because that's where the incision is, so skin mostly incisions. But we also, like I said, modify in the setting of what bugs a patient may be colonized with. And this is a table that we have that's available on our stewardship website. And you can see this is for the anesthesiologists in the OR. They know the dose to give of the particular antibiotic that we recommend at the time of transplant, and they know how often to redose it in the OR. So because this patient was going for a liver transplant, we normally would have given Amsulbactam, but because, as you saw, he was colonized with that very resistant bacteria, that carbapenem resistant Klebsiella, we modified his perioperative prophylaxis, knowing that he was at risk for that particular bacteria with infection after transplant, and we gave him tigecycline. Even despite us giving him broader antibiotics, knowing that he was colonized with that to prevent surgical site infection, post-op day 5, you were called from the ICU because the patient develops fever and hypotension along with increased tracheal secretions. Blood and sputum cultures are sent. And as the ID consultant, or let's say you're rounding with me as the resident, you are called for empiric coverage for septic shock. You start 1, gentamicin, 2, colistin, 3, ceftaz-avi, 4, zerbaxa, 5, tigecycline, or you choose to call an ID consult. What do you want to do? And if you don't know, that's okay too. That's the whole point of this.
Yeah, I will call ID consult at that point.
Good answer. So here we started ceftaz-avibactam, and we're going to talk a little bit about carbapenem resistant Enterobacteriaceae. And this is the club that grew out of this patient's I believe this is sputum. So you can see, not surprisingly, now this is tigecycline intermediate. It's still polymyxin or colistin susceptible, and it's not here, but it was ceftaz-avi susceptible. And so these are often the types of infections that we're dealing with in the immediate post-transplant period. So carbapenem-resistant Enterobacteriaceae, like this patient has, is described by the CDC as an urgent level threat. It's responsible for many drug-resistant infections per year and is associated with high morbidity and mortality. And this is a slide from 2009 and 2010. So CRKP was first described actually back in 2005, 2006, but you can see became endemic to New York back in 2009, 2010. And since that time has quickly spread all over the country and is basically now endemic everywhere across the world, basically. This was a study done out of our own institution back in 2011, showing that CRE, like this patient had, was associated with higher mortality after liver transplant. And these are the risk factors associated with CRE. Again, a study done out of our own institution. You can see that being a transplant recipient is independently associated with having CRE infection. As is mechanical ventilation, as was this patient, as is prior antibiotic therapy. And we know that many patients who are going into transplant are like this patient. They've had a lot of nosocomial exposures. They've been in the hospital, in and out a lot. They've had antibiotic exposure. And so that often puts them at risk for these more multi-drug resistant organisms that then we often have to deal with after transplant. How do you treat or manage CRE? Well, first of all, source control is really important, and that wasn't a factor here, but if we know a patient has an abscess or a line, for example, it's more important even than the antibiotics, and that's what this table is showing, is that if you use a procedure to remove the probable focus of infection, such as debridement, drainage, or catheter removal, that's associated with higher survival than just antibiotics alone. And the good news is that now we have more antibiotics than we used to. So these are some of the older antibiotics that we used to have to treat these patients: tigecycline, colistin, gentamicin. But I don't know how much you know about many of these antibiotics, but colistin, for example, is associated with significant nephrotoxicity and neurotoxicity. Tigecycline is not great for bacteremia or septic shock, although it's good for intra-abdominal penetration and pneumonia and skin and soft tissue infection. And gentalone is also not great for these type of bugs and is associated with nephrotoxicity. So the bad news is that this is a severe infection, but the good news is that we have great antibiotics now to treat it. And one of these new drugs that we have is called ceftaz-avi. Ceftaz-avi, or avibactam, or sorry, Avi-Cas, is a novel cephalosporin beta-lactamase inhibitor that has activity against carbapenem-resistant Enterobacteriaceae. In this one particular multi-center retrospective study that looked at treatment with ceftaz-avi for CRE at 9 different health systems, there was still a significant mortality rate, which is not uncommon with CRE, but the good news is that monotherapy with this drug was very similar to combination therapy with these older drugs. And of course, not surprisingly, we already do have resistance emerging with ceftaz-avi. And as you can see here, this table shows you that ceftaz-avibactam is not the only drug that is now approved for treatment of CRE. So CRE activity is represented by this class here, and I'm not going to go into this today. I'm happy to come back and do a multi-drug resistant organism talk if you like me to, but there's different types of carbapenemases that are associated with carbapenem-resistant Enterobacteriaceae. The most common one that we see in the United States is KPC. And so you can see ceftolozone tazobactam, for those of you who may have heard it, is often called Zerbaxa. That's the brand name. That does not have activity against CRE, but it has good activity against ESBL and difficult to treat Pseudomonas. Ceftaz-avi is a new drug that we can use for ESBLs, KPCs, like this patient had. Meropenem ribarbactam is another new drug that was recently approved and also has activity against carbapenem-resistant Enterobacteriaceae, specifically KPCs, as does these two drugs, also recently approved and available, imipenem relebactam and ceftarixol. So the good news is that we do have now newer drugs available for these sort of multi-drug resistant infections that we often see after transplant. And we have to be both conservative and thinking about stewardship because we want to be able to use them appropriately in the right post-transplant setting if a patient does have infection with these organisms. So moving on to case 2, this is a 60-year-old woman with liver transplant who has hepatic artery thrombosis, a biliary leak, and she develops what we call a biloma. And this is what her cultures grow. And what is this? Anyone can unmute and chime in.
VRE.
Good. Okay, excellent. So this is a vancomycin resistant Enterococcus speciem. So, and how do we treat this? We usually use linezolid, right? Or daptomycin. So this patient did get linezolid twice, unfortunately, and then she's readmitted again. And this time you drain her culture, and what happens now? Drain her collection, and what happens now?
It is now resistant to linezolid.
Exactly. So this is a problem. And so you can see here that this isolate luckily is still dapto susceptible. So you can use dapto to treat it. It's also TIG susceptible. So that's potentially an option. But you know, the emergence of linezolid resistance as well as daptomycin resistance in VRE isolates is being described with increasing frequency, especially in transplant recipients. So this is not an uncommon thing that we see, especially in liver transplant recipients. Risk factors in liver transplant recipients for VRE include ICU admission, prolonged hospitalization, renal failure, surgical factors such as OR time, biliary strictures and leaks, like in this patient. Mortality can be increased in these settings, as well, especially in the setting of reported linezolid and daptomycin resistance. So these examples of infections were cases that were good examples of the types of early infections that we see in that peri-transplant, post-transplant period, the immediate less than 1 month post-transplant period. And like I said, they can be occasionally donor-derived, but most commonly what we see are healthcare-associated bacterial infections, such as surgical site infections, wound infections, pneumonias, catheter-related infections, C. diff, and this is not usually a time period where we're seeing an OI, okay? So like I said, bacterial infections are very, very common, as I described, and similar, like we talked a little bit about risk factors. This goes a little bit about bilomas, because we talked a little bit about this case. Bilomas are really common in liver transplant patients in particular, because you know, you're doing a biliary anastomosis, and so if you have issues there, you can have a leak, and then you can have a biloma that develops. It's also frequently associated with hepatic artery thrombosis, because if you have ischemia that is in the liver, that results in the liver graft, then that can put them at risk for a biloma. And many times mortality can be increased in this setting. And the management is like we talked about, drainage and antibiotics. I also mentioned Canada very quickly here because it's a common thing that we see, especially after liver transplant. And these are the typical risk factors for Canada. So fulminant hepatic failure, retransplant, renal failure, prolonged OR time, excessive blood loss, repeated surgery, prolonged antibiotic therapy. And if you have this risk factor, then in addition to Unison at the time of your liver transplant, you would be getting fluconazole. Any questions about that early, less than 1 month period before I move on to the second phase?
Dr. Rana, not necessarily about this, but there was a question in the chat from Avinav. So he's wondering about the emergence of resistance to the Septas-Avi among CRE and wondering if we have to do susceptibility testing before prescribing.
Yes, that is a great
question. I think my question was whether you do an E-test before for a meropenem resistant organism before going on to Avicaz, like an extended infusion of meropenem test.
So what we typically do, and if you round with me, then you'll see I go through a lot more detail of how we do resistance testing. And so nowadays we have a couple different things that are a little bit different than we used to basically have. We have now rapid identification actually that tells us if an organism is producing a carbapenemase. So oftentimes we'll know that ahead of time genotypically if that is present, if that beta-lactamase is present. But in terms of your specific question about susceptibility testing, yes, we obviously do susceptibility testing by something called a microscan. We'll get susceptibility results back. And so we'll actually now have a lot of times we'll have the carbapenem results back and we'll have the AVCAS results back immediately. And so we'll know which drug to use. And sometimes you may not see the AVCAS come up immediately, and that's because it may be suppressed. And so if it is suppressed by the lab, you can call your ID fellow or your ID consultant, and they can sort of quickly find out for you if the AVCAS is susceptible or not. But I would not, if it's a known CRE, like if I know that there's a KPC present based on my genotypic testing, for example, then I would not give carbapenem, because even if you did an extended infusion of a carbapenem, it's not going to help since it has a carbapenemase, and that's when you really want to go to your better drugs in that situation. Does that answer the question?
Yes, yes. Thank you so much.
Okay.
There's another question in the chat, if that's okay, Dr. Rana. So Fatima, I'm not going to read directly this time. Do we consider CRE as a potential contraindication to transplant, especially if transplant failure or if transplant has failed multiple times?
So great question. And this is something that we talk about a lot, not just with CRE, but any sort of resistant, multi-drug resistant organism pre-transplant, is how do you decide whether or not it's safe to transplant someone like that. And that's why it's so important that we work in conjunction with our transplant group to make those decisions. Oftentimes what we do is we talk about the patient, we go to the recipient review, we discuss with the transplant physicians and the transplant surgeons whether or not we think, is it safe to transplant this patient? And we take a lot of factors into consideration. So for example, is someone colonized with the CRE? That does make them high risk for me, but it's not necessarily an absolute contraindication, especially if I have drugs to potentially treat them. So in this situation, it was TIG sensitive. I knew I had Septaz Avi, and I have newer drugs now that I can use to treat. So now we're in a better spot, specifically with CRE when it comes to transplant, than perhaps we were 5-10 years ago. And there has been more data suggesting that in patients who are colonized with CRE, they are at higher risk for infection, but mortality is not always necessarily as increased as it used to be, given that we have better drug options. But I will tell you, this question comes up all the time. I have a patient right now waiting for a liver transplant on the floor who we've gone back and forth about, who's colonized with an XDR Pseudomonas. Who's on polymyxin, who our plan is to give, cefderical. So this question comes up all the time, and it's not a simple yes or no answer. It depends on multiple questions. That particular patient who's waiting for a liver, I know the source, it's a TIPS, and as soon as I can take that TIPS out with and put in a new liver, I'll get rid of that resistant bacteria. So, there's sort of different things that you want to think about. Are you going to be able to achieve source control? Do you have drugs to treat the patient with? And then there's other risk factors that you think about as well. So it's an ongoing conversation that you have with the transplant team. And that's why we see these patients before transplant, so that we can weigh in on the infection risk. But great question. Okay. Moving on, I think, right? Okay. All right, so moving on to opportunistic infections, and we typically begin to see this in sort of that intermediate phase, okay? And that's because when you really have sort of the nadir host cell mediated immune function, and we're going to talk about some of these OIs. So this is a 41-year-old with HCC, has a liver transplant 6 months ago. He's coming in with fever, chills, nausea, vomiting, abdominal pain, and diarrhea. You know that he recently had an increase in his immunosuppression, specifically CellCept because of rejection. He's also on Prograf and prednisone. You also know that his prophylaxis has been recently discontinued. So typically in these patients, the valsite and the Bactrim are discontinued at 3 months. And you also know that he was donor positive, recipient negative for CMV. He's febrile to 38. He has bilateral crackles and diffuse abdominal tenderness on exam. Any thoughts? This could be a lot of things, so.
It could be an opportunistic infection because it has been more than 6 months, but at the same time, we can think of like community infections as well. So he was donor positive, recipient negative for CMV. That means that the donor was positive for CMV, but then the recipient was negative. It's possible that he could have also CMV as well and has an increase in immunosuppression.
Very good. That's exactly the line that I wanted you to pay attention to in this case. So you really can't give a transplant ID talk and not talk about CMV. This is hands down one of the most common infections that we see after transplant. And so, this patient had a low white count and low platelet count, and this is very common in CMV infection that we'll see thrombocytopenia and leukopenia. And when the CMV PCR was sent, it came back greater than 100,000. And this patient was started on IV ganciclovir. So as you pointed out, patients who are at highest risk for CMV after solid organ transplant are those who the donor have been exposed to CMV, but the recipient is still seronegative. So remember, CMV is a herpes virus. 85 to 90% of the population has been exposed, and it remains latent. So if you have a donor who was exposed to CMV as a child, or they had exposure as indicated by antibody, but your recipient was one of those 10 to 15% of patients that never had exposure to CMV, that particular group is at highest risk for reactivating CMV after transplant. It's not to say that the other groups, if your recipient's seropositive, you can't also reactivate CMV after transplant, but this group is the group that we worry about the most. And that's because after the prophylaxis is discontinued, many of them will reactivate. And what do we worry about when we think about CMV? So there's the direct effects and the indirect effects. So the direct effects of CMV are usually the types of things that we see with CMV infection. So like this patient, fever, myelosuppression, malaise. CMV can also be invasive and then be called CMV disease. And it can be called, there's often mostly GI disease is what we'll see, but you can also see hepatitis and rarely pneumonitis, CNS disease, or retinitis. But in transplant patients, we also worry about indirect effects associated with CMV. So often patients who develop CMV are at risk for rejection or fungal or other bacterial infections after they develop CMV infection. So how do we treat CMV? The good news is CMV, we have a lot of good treatments now. And the most common treatment that we use is IV ganciclovir or oral valganciclovir, which is basically the oral prodrug of IV GCV or IV ganciclovir. So this patient had severe disease and had a very high PCR, so he received IV GCV. But in mild to moderate disease, we'll treat with oral valsite or oral valganciclovir. Typically, we give, this is the most common dose we use for good renal function. We try to avoid dose reducing just to prevent leukopenia, for example, because that'll set up patients for resistance and inadequate clinical efficacy. If a patient does present with severe disease, like in this patient, oftentimes we'll work with the transplant team to reduce the immunosuppression as well. And that often means halving or holding the cell sept in particular. And then we monitor the CMV PCRs and look for improvement. Usually what you'll see in a patient like this is that their symptoms will improve first. So they'll start to defervesce, the nausea, vomiting, abdominal pain will go away. And usually it takes about 2 weeks, actually, not just the first week, but usually it takes about 2 weeks before you see the PCR start to fall, all right? If after 2 weeks, the PCR though is still elevated or the patient is not feeling better, then you sort of need to think about resistance testing. And we'll often then send resistance testing to look for resistance to ganciclovir or valsite and think about other treatment options for CMV. like foscarnet. And the good news is with CMV, as I said, we have a couple drugs. We have ganciclovir and valsite. We have foscarnet, although foscarnet is associated with renal insufficiency. And more recently, just if you heard in the news, this drug, maribavir, received FDA approval for management of resistant CMV. So if you have a patient with resistant CMV, this drug can now be considered. This was a phase 3 study that looked at 354 stem cell and solid organ transplant patients who had resistant or refractory CMV. And maribavir was effective in achieving its primary endpoint, which was confirmed CMV clearance at week 8. And they found that the most common side effect with maribavir is dysgeusia, but actually, when they compared it to foscarnet and GCV and valsite, there was less AKI than foscarnet and less neutropenia. So one complication of ganciclovir oftentimes is leukopenia. So maribavir didn't do that. So look for this drug to come, hopefully, and start being used in the future. But now this is an option for resistance. But hands down, the most common drug that we use for CMV is ganciclovir or valsite. Okay. So case 3, unless anyone has any quick questions about CMV.
I would just like to add, is PO valganciclovir more effective than just valacyclovir for CMV?
Yeah, so valacyclovir is Valtrex, right? And we use that for HSV. But for CMV, we have to use valganciclovir or valsite for efficacy against CMV. That drug also has efficacy against HSV. So valacyclovir is the treatment of choice for HSV or VZV. For CMV, we have to use valsite or valganciclovir. Does that make sense?
Yeah, so is that what you would use for prophylaxis as well, or?
Yes, so for prophylaxis for patients who are CMV seropositive or their donor was CMV seropositive, we use valganciclovir.
Okay.
If they are not CMV seropositive, then their donor is not CMV seropositive. So if both are CMV negative, then we'll just prophylax for HSV and use valacyclovir.
Okay, understood. Based on the table that you showed.
Yes, exactly.
Okay. Thank you.
All right, so case 3 is a 67-year-old man with cryptogenic cirrhosis, status post-liver transplant in June of 2011. He presents 3 months later with headache, slurred speech, and weakness. And you are told his blood cultures are growing yeast. An LP is done. The opening pressure is 55. He has 8 white cells in the LP, a slightly elevated protein. And there is a diagnostic test that is done. So just to go back to this case, he has a headache, blood cultures have yeast, he has a high opening pressure.
It could be Cryptococcus. We usually can give high opening pressure.
Very good. Yep. So this is cryptococcal meningitis, okay? So we sent a serum. So the diagnostic test that we did was a cryptococcal antigen. So we sent a serum cryptococcal antigen, which was very positive, and a CSF cryptococcal antigen, which was also very positive. This is a picture of the India ink stain, right? Which basically stains the capsule. So Cryptococcus is famous for its capsule, right? And the CSF culture and the blood cultures here grew Cryptococcus. So Cryptococcus is described as 8% of invasive fungal infections that we see in solid organ transplant recipients. The median time to onset is late, 16 to 21 months, but it can occur earlier, as was described in this case. And it can represent reactivation of latent infection in the setting of immunosuppression after transplant, but it can also be primary infection, and rarely it can be seen as donor-derived infection, especially if seen within 30 days after transplant. So how does Cryptococcus typically present? Many times it can just present as an isolated pneumonia. So sometimes we'll just see cryptococcal pneumonia alone. But because Cryptococcus does have a predilection for the CSF, oftentimes we will see CNS infection or meningitis. And sometimes, rarely, we can also see skin and soft tissue infection. So up to 33% of patients with cryptococcal meningitis will have fungemia. Cryptococcal antigen testing is a very good test for cryptococcal meningitis in particular because it's very sensitive, and patients with cryptococcal meningitis will have a positive cryptococcal test. So we often, train our transplant teams that if you have a post-transplant patient coming in with a headache or a post-transplant patient coming in with headache and fever, send off that cryptococcal antigen test. It's not hard to do. You can send it in the serum. And if you if you miss cryptococcal meningitis, it can be really associated with high mortality. So it's an easy test to do to send off in the serum if you have a transplant recipient coming in with headache and fever. Patients with suspected cryptococcosis should have an LP done to rule out CNS disease, and that's because of Cryptococcus's predilection for the CNS. So even if you have isolated pulmonary disease, we will typically ask you to do an LP to make sure we're not missing meningitis. And remember to check an opening pressure in this case because it affects the management, right? So in cryptococcal meningitis in patients with CNS disease, especially in patients with an elevated intracranial pressure, you have to do an LP daily to sort of relieve that opening pressure and to relieve that CSF until you bring the pressure down to normal. And patients with CNS disease will receive ambisome and flucytosine therapy, usually for an induction period of about 2 weeks if they can tolerate it. And I say if they can tolerate it because many times ambisome is associated with nephrotoxicity and flucytosine with bone marrow suppression. And then we'll transition to maintenance treatment therapy with fluconazole for 6 to 12 months. Oftentimes in transplant patients too, you need to watch out specifically for immune reconstitution, inflammatory syndrome, or IRIS if you rapidly reduce the immunosuppression. So we're very careful what we do with the immunosuppression in this situation, because sometimes if you dramatically reduce the immunosuppression and you treat for Cryptococcus, you'll see sort of an inflammatory response as well. Questions about Cryptococcus?
There's one question in the chat from Archana. She's wondering how often are blood cultures positive? So how often do we have cryptococemia in cryptomeningitis?
Yeah, it's not all the time, okay? So definitely, I think I said 1/3 of the time we'll see positive blood cultures. So definitely that's why you want to do an LP because it may not always grow in the blood. So you want to do an LP and make sure you're not missing Cryptococcus.
I also have a question about a similar subject. Can you clarify about the serum cryptococcal antigen? Is it sensitive to any type of cryptococcal infection? What's the, I guess, negative predictive value of it?
So great question. It's a good test and it has a good negative predictive value for cryptococcal meningitis, okay, in particular. It's not great for isolated pulmonary cryptococcus or cryptococcus, for example, if it's just in another area like the skin, for example, which is uncommon, but I have seen cryptococcal infection just present as a skin and soft tissue infection. And in that case, you have to do a biopsy really to rule it out, and the antigen may or may not be positive. I've definitely seen isolated pulmonary cryptococcus diagnosed on bronchoscopy, and the antigen has been negative. It can be positive in those situations. It's just not as great of a test as it is for meningitis. But meningitis is really the one that's, where you don't want to miss because it's really associated with high mortality after transplant. So that's why in patients post-transplant who are presenting with headache or headache fever and you think about meningitis, it's an easy test to send from the serum because of its sensitivity. So we often, do train the transplant teams to send it if they have a post-transplant patient with headache and headache fever. Does that answer your question?
Yeah, thanks.
All right, so I'm moving on to the next case. This is a 62-year-old man with HIV. He has a liver transplant and he presents for routine clinic follow-up. You send a Prograf level, and for those of you who are not familiar with Prograf levels, this tacrolimus or Prograf level is very, very high. It's 57, and usually you're looking for 8 to 10, for example. Any particular things that come to mind when you see such an elevated prograph level in a patient with HIV?
I think you want to make sure that they don't have any new renal dysfunction that could
Okay,
be causing tacrolimus
very
to accumulate.
okay, good. Definitely, of course, you want to check the renal function 100% because that could be a reason for that.
I'm not sure if the antiretroviral therapy can interact maybe with the tacrolimus.
Yes, that's exactly what I'm getting at here. So boosted protease inhibitors, when used to treat HIV, oftentimes interact with the tacrolimus and can really result in an elevated tacrolimus level. And so ideally, patients with HIV, when we're evaluating them before transplant, we switch them off the protease inhibitor and usually give them either just a nucleoside or NNRTI regimen or an integrase regimen, basically before going into transplant. If someone has to stay on a protease on that particular class of drugs after transplant, then we have to be very, very cautious about how we dose their Prograf. They often need very, very little Prograf. So most transplant patients take Prograf twice a day. Transplant patients with HIV who have to stay on a protease only take 0.5 milligrams once a week, for example. And it's very, very difficult to dose. So in that particular patient, the reason his level was 57 was because we switched his HIV meds off of the protease. We put him on an integrase-based regimen. But when he was discharged from the hospital after his transplant, he started taking his old meds again. He started taking his old HIV meds. And then when he came back, his level was 57. And he had to be admitted for Prograf toxicity. So I like to talk about HIV and transplant a little bit because not just to teach you sort of a little bit about the drug-drug interactions and how drug-drug interactions are something we think about a lot in Transplant ID, but also just because we're a very big center here for HIV and transplant. So for those of you who don't know her, this is Elmi Mueller. She's a surgeon in South Africa who more than 10 years ago started transplanting patients with HIV. And the unique thing that she did was that she used HIV positive donors. And what she found was she had patients her patients with HIV could not receive dialysis because they just didn't have the resources. So instead she transplanted them and she used a kidney in her patients with HIV, she took a kidney from a deceased donor with HIV. And that was very unique at the time and had never been done anywhere else in the world. And she found that just because she used a kidney from a donor with HIV, her patients with HIV had very good graft and patient survival after transplant. She ended up publishing her findings in the New England Journal of Medicine. And subsequently in 2013, President Obama passed the HOPE Act into law in the US. We were not previously allowed in this country to use donors, organs from donors with patients with HIV. And President Obama signed the HIV Organ Policy Equity Act, which allowed us to start using kidneys and livers from donors with HIV and also allowed patients living with HIV to now register to become organ donors. So since 2016, the first HIV to HIV kidney and liver transplants have been performed. The first one was done at Johns Hopkins. It's done under an IRB approved protocol, but with NIH funding. So it is still under research. There are 22 transplant centers that have been approved. We are a big transplant center here that performs HIV to HIV transplantations. There have been more than 300 done across the country. We've done 99 here at Sinai. We're a very big HIV to HIV transplant center. And so I bring this up because you may see some of these patients being admitted and also it's also important to think about your own patients with HIV and end-stage liver disease and end-stage renal disease, because transplantation has really become the standard of care for those patients because HIV is no longer a contraindication at all to transplant. Transplant is really the standard of care. And now we can use HIV positive donors, which helps speed up their time on the wait list. Case 5 is a 72-year-old Korean woman with Hep C and Hcc. She presents 3 months later with fevers, abdominal pain, nausea, vomiting, and pancytopenia. She develops a rash and she becomes acutely hypoxic, requiring 100% FiO2. This is her chest CT, and this is, it says diffuse infiltrates basically, and then you can't really see, but she has a rash all over here on her skin. I'm just going to tell you what this is because otherwise it's really difficult. So she has a BAL done because she's intubated in the ICU, and I get a call from the lung pathologist saying that they see worms. And then we basically go to the microlab, to the parasitology lab, and look at her BAL specimen. And behold, there's moving strongyloides. And so strongyloides is an intestinal nematode that's endemic to tropical regions of the world. It has a very high global burden of infection, and it has a unique auto-infection life cycle, meaning that patients may have been exposed to it, but they're often maybe asymptomatic until after transplant when they receive steroids, and then that can lead to hyperinfection or disseminated disease. So as I described, strongyloides is endemic to many, many parts of the world, including the US, southern parts of the US. And so oftentimes we will, patients who describe living in any of these tropical climates, we will send a strongyloides IgG off pre-transplant to see if they've been exposed. And if they have, we will treat them ahead of time before transplant to avoid hyperinfection or disseminated disease after transplant. And like I said, this is the autoinfection cycle of strongyloides. And patients can often, this often results in hyperinfection or disseminated disease in the setting of steroids after transplant. What's unique about this case, actually, and we ended up writing this up, was that the donor testing was positive for this patient. This patient was from South Korea, but the donor was from Puerto Rico. And so we ended up going back and doing donor testing, and the donor had a positive strongyloides IgG. And so probably this was a donor-derived infection, and this patient ended up reactivating strongyloides after transplant. This patient did well. She was treated, despite having hyperinfection or disease, she was treated with ivermectin and albendazole. And so, like I said, current guidelines recommend antibody testing for patients from an endemic area. And strongyloides, for those of you who haven't seen it, when presents with hyperinfection or disseminated disease, can often present with pneumonitis. Because it goes through the gut and translocates into the bloodstream, you'll often have bacteremia associated with it, and oftentimes gram-negative meningitis as well. So it can be very severe, but we often say that if you're seeing a post-transplant patient with eosinophilia, for example, this is the type of thing that you may want to, or GI symptoms that you may want to think about this particular bug. Going to move on to talking about that late phase, greater than 6 months. So typically after 6 months is when we start to think about community-acquired pneumonia, respiratory viruses, more community-acquired infections, because that's when patients sort of go back to living their sort of, lives. But you also at this point still want to think about the risk of OIs, because it's still, possible in this time period, especially if patients have been treated for rejection. Many of the cases I presented today, you saw patients were further out from transplant. So this is a patient who had lupus and then had a kidney transplant in 2006. She's 4 years out, but she's treated for rejection with T-cell depleting therapy, ATG, and steroids. And she presents 6 months later with cough, fever, myalgias, and this is her chest CT. Any thoughts on this case? So what do you see here? Someone just describe what they think they're seeing.
I would say there's a small consolidation on the base of the right lung.
Okay. Do you guys also see, you're seeing nodules? Do you see that? Yeah. So there's this patient's chest CT had essentially like a nodular infiltrate, right? Okay, and this is almost like a halo here. So this was invasive aspergillosis, okay? So this, when the pulmonary pulmonologist bronched this patient, they wrote this in their bronchoscopy note, the mucosa of the right main bronchus appears to have been erosive, irregular, ulcerated, and white, and there appears to be a necrotizing process that's eroded and destroyed the medial wall of the left main stem. So this is aspergillosis. This is a pretty common invasive fungal infection that we see after transplant. Oftentimes, it traditionally used to be described earlier, but nowadays more commonly for us to see it after 6 months or even after a year. The diagnosis is typically made, in this patient it grew from the BAL, but oftentimes fungal culture is not so sensitive. So we will use other techniques to try to diagnose aspergillus, which can be very difficult to diagnose. So oftentimes we'll use galactomannan, which is found in the cell wall, either through the serum, or we'll send it from the BAL even, which is more sensitive, or we'll look at the pathology if the patient's been biopsied to help us make this diagnosis. The treatment of choice for aspergillus is voriconazole, which does have a significant drug-drug interaction with tacrolimus, and so we have to be very careful when we use vori to treat these patients because we have to dose reduce the tacrolimus significantly. Or you can also use ambisome, but obviously that's IV and associated with renal failure. So our drug of choice for aspergillus infection usually is vori. And I'm going to move on to my last case, and then we can just end with questions after that, if that's okay. So this is a 55-year-old man, knee transplant in 2020, presenting with cough, congestions, myalgias. He's diagnosed with COVID-19. He's vaccinated ×2, so this is a case from last year. And he presents 2 weeks later with hypoxic respiratory failure in the ICU. And you send an anti-spike IgG to see if he has any antibody to his vaccine, and he does not. So I talk about this case because it's very hard to not talk about COVID right now in transplant. It's such a hot topic. And I'm sure many of you are seeing these patients. This is a study published in JAMA last year, which basically looked at post-vaccination antibody response in SOT. And you can see only 15% of patients had an antibody response to 2 vaccines. 46% of patients did not. And so based on this study and a couple other studies, the CDC changed guidance in August of 2021 to suggest that transplant patients and immunosuppressed patients should be getting a 3-dose vaccine series. And so this is constantly changing, and this actually just changed again 2 weeks ago. And so I want to bring it up here so that you guys are aware of what the latest guidance is for transplant recipients and COVID vaccination. So all transplant recipients should have 3 COVID vaccines done at a minimum, and this is 3 COVID vaccines because that's their primary series. So if a primary series for an immunocompetent patient is 2 COVID, I'm talking about mRNA, 2 COVID vaccines. For a transplant patient, it's 3. So, and the recommendation for Pfizer is their first dose followed by their second dose, and then their third dose 4 weeks after the second dose. And what's been changing recently now is the recommendation for the booster dose for transplant patients. So like everyone else, you guys saw that the booster dose was for 6 months and then 5 months. And as of 2 weeks ago, they've now changed this again to say that transplant patients can now get their booster dose as early as 3 months after their third dose. So just to be clear, all SOT recipients have a 3-dose series, not a 2-dose series. They have a 3-dose series for COVID vaccine after their transplant. And that's because of the data suggesting that most transplant patients don't mount a response with just 2 doses. Some patients after even 3 doses won't have a sufficient vaccine response. We'll talk about that in a little bit. And then all transplant patients should get their booster dose at 3 months after their third dose. If they've gotten Johnson & Johnson, And the recommendation is to do the first dose, to give them a second dose of Johnson & Johnson, and then to get their booster dose 2 months after. And you can mix and match and obviously do like an mRNA booster for these patients. So for patients who have had 3 doses, and you check their anti-spike IgG and they still don't have an antibody response to their vaccine, or they've had their booster dose, their 4th dose, and even some of these patients will still not have a response. So after you give the 3rd dose, about 15 or 20% of patients will get that response, but sometimes some people won't. And what are your options then in those cases? And as you can imagine, this is a really common cause for ID consult at this point. What do we do with a transplant patient who's gotten 3 or 4 doses and just has no antibody response to their vaccine? So there was a new drug approved for this population called Evusheld. Evusheld is a combination of 2 monoclonal antibodies directed against the anti-spike protein. It received FDA emergency use authorization for PrEP, or pre-exposure prophylaxis, in those who are unlikely to mount a response to COVID-19 vaccination. I can tell you there's questionable efficacy against the Omicron variant. So for patients who receive this, we tell them, please still be careful. But it does look like that Evusheld does have better activity against the BA.2 variant coming down the line. And what we recommend to see if you qualify this is for after your last vaccine dose to check an anti-spike IgG, and if it's negative, and you have no evidence of antibody, then you can email covidprep@mountsinai.org. There's a red cap link that you can fill out for your patient, and then they will be considered for Evusheld. What are other options for these patients who are not mounting a response to vaccine? There's a new study that we just opened up here. Again, I'm mentioning it, COVID-19 protection after transplant studies. This is an NIH multi-center study looking at giving patients an additional vaccine dose and randomizing them to an arm to decrease their immunosuppression, to see if we hold the cell receptor, if we cut the tacrolimus, does that help a patient mount a response to the vaccine? And so that's what this study is going to be looking at. And this was an article in the New York Times just last week. And you can see this article talks about transplant patients and other immunosuppressed patients, such as patients with cancer, continuing to feel vulnerable to the virus because they're unable to or mount a response to vaccine, and so are at higher risk for complications from COVID-19. So how do we counsel these patients? We obviously, because the guidance is constantly changing. I just showed you the most updated guidance as of 2 weeks ago. Most importantly, of course, get your vaccine, stay up to date, get your 3rd dose and your 4th dose. If you're due for your booster, go and get it. You'll be surprised as to how much people still don't know and how many providers still don't know that transplant patients are eligible for their 4th booster dose. We tell patients that you want to create a cocoon. You want to be surrounded by patient friends and family members who are all vaccinated. And that's the best way to keep you protected from this infection. And we tell our patients that unfortunately all these new guidelines coming out where you don't have to mask, blah, 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 unfortunately doesn't really apply to the patients that we're seeing. So we tell them, keep your mask on, avoid those crowded, poorly ventilated spaces, continue with the social distancing. And then if you do still happen to come down with COVID-19, and especially if you're antibody negative and you don't have response to vaccine, seek out early testing, because we can get you early treatment with monoclonal antibodies if you test positive and have symptoms. So COVID-19 and transplant is really an evolving, rapidly changing field, and something where I and a lot of transplant ID providers spent a lot of time doing. And I just wanted to end a little bit with talking about prevention, especially in that late phase after 6 months, because many patients who are even years out after their transplant are still having to deal with this right now. And that's it. So in summary, the risk for infection in a post-transplant recipient is determined by a combination of factors: epidemiologic exposures, and the net state of immunosuppression. Remember the timeline of infections. Early infections are typically nosocomial or surgical site infections. OIs often present later, and especially in the face of augmented immunosuppression, and late infections can often be related to community exposures. And specifically, microbiological diagnosis is always helpful. In all these cases, you can see we had a microbiological diagnosis, and that's really critical to helping guide treatment in the transplant patient. And that's it.